Thank you so much. And thank you, everyone. And welcome for those of you that don't know me. I'm Melanie Henderson. I'm the Vice President of Clinical and Support Services at Pembroke Regional Hospital. And I have the pleasure of introducing today's mini-series session. So we do, as part of our OHT, we do offer those mini-series as a way for us to have some, shorter interactive session and really informative sessions between our regular collaborative partners forum sessions. We hope that this one would provide, members with a focus, small group presentation, and the opportunity to ask a lot of questions and have some discussion on one of our priority area. So today, before we get started, we're going to move forward. We're going to do our land acknowledgement, and then I'll introduce our speakers for the day. So we at the Ottawa Valley Ontario Health Team will begin collaborative partners forums by acknowledging that we are meeting on Aboriginal land that has been inhabited by Indigenous people from the beginning. As settlers, we're grateful for the opportunity to meet here, and we thank all the generations of people who have taken care of this land for thousands of years. Long before today, as we gather here, there have been Aboriginal people who have been the stewards of this land. In particular, we acknowledge the traditional territory of the Algonquin and the Anishinaabe. We recognize and deeply appreciate the historic connection to this land. We also recognize the contribution that Métis, Inuit, and other Indigenous people have made, both in shaping and strengthening the community in particular, as well as our province and county as a whole. As settlers, this recognition of the contribution and historical significance of Indigenous people must also be clearly and overly connected to our collective commitment to make the promise of the challenge of truth and reconciliation real in our communities, and in particular, to bring justice to the missing and murdered Indigenous women and girls across our country. Thank you. So today's session is related to one of our top priority, as mentioned. We build on really looking at mental health, substance use, and addiction, and really looking at increasing our peer support and the role and the services of the care providers, beginning with a pilot project that has been implemented here at Pembroke Regional Hospital. So this pilot project was developed over the past few months and began in early June. And I will now turn it over to the team. So happy to welcome Leanna Sullivan, Mike Morrison, Courtney Hodgins from Mackay Manor, and Kaylee LaMarche, who will talk to us about people with lived experience and ED Pathways to Community Services Pilot Showcase. So over to you, Leanna.
Great, thank you. So I'm just going to give you a little bit of a background to the project, how it came about, and how this all started. And then I'm going to turn it over to the folks who are actually on the ground making this happen. So this, as Melanie was saying, was one of our key projects at the Mental Health Substance Use Health Network table. And it was to address the wait times at hospitals for individuals presenting with substance use and mental health issues, and to hopefully enhance their access to community services. This actually came down as a provincial directive to be looking at wait times. So one of the key components to do this work was to have individuals with lived and living experience involved in the discharge planning process and offering supports to our clients and to the folks presenting to facilitate the individuals in transition from hospital to community care to the community resources. We knew that if we invested in the services that offered mental health and addiction services and have them connected directly to the hospitals, we could divert individuals from the emergency rooms and to support a more appropriate community-based program intervention. So utilizing peer support to do this work has been identified as a core service across the spectrum of need. So to do this, we wanted to look at what are the barriers, what could some of the barriers be. Anti-stigma training was identified as a fairly large barrier and a priority by the Ottawa Valley OHT members. So that became, the initial part of this whole project. Phase one of this project was to have all frontline staff complete the anti-stigma training called Stigma Ends With Me, offered through CAPSA. Many frontline staff completed this training, including the ED staff, and I believe that was done around January, February of this year. It was completed. So that was phase one of the project. So we've launched into phase two of the project, and this has, we're hoping to build on this training and support professional relationships between people with lived and living experience and the frontline staff of our pilot partner, which is the Pembroke Regional Hospital. Courtney and Mike are going to talk a lot more about that in the next few slides. And you know, in what they're doing and how they're rolling that out and what that's looking like. We do have a phase three that we're hoping we can get to at some point, and that's actually having a peer support point in the ERs to be like a point contact for folks presenting to the EDs. And that's all that I have for the background.
Wonderful. Thank you so much, Leanna. I think we may still be waiting on Mike. He may be having some trouble logging on. Can I just ask, is Mike on the line? If not, we'll move ahead in the slides and hope he can join us. Mike, are you there on the line? Okay, we'll give Mike a little bit more time. Hopefully he can join us later. And Courtney, we'll just move Courtney and Kaylee will move on ahead to your section if that's okay.
For sure. So we have started phase two of this project by incorporating, of course, the people with lived experience. We actually have been twice now to PRH. We've decided to do the first and last Wednesday of every month at 11 a.m. to go in and chat with the staff in the ED and visit anybody who is admitted to the emergency department. So far it's been going really well. Maybe still working out some kinks, but it's off to a really good start.
And then maybe I'll just add to that,
yeah.
That I had the pleasure of listening to Mike speak at the Mesa gathering, or sorry, Leonard speak at the Mesa gathering. And I think that was a great precursor to just his compassion and his empathy and what he's bringing to the table at the front line. Right off the get-go, the staff have been really receptive to both Mike and Leonard. And that goes both ways, actually. The first day that they were in the department, it was extremely busy, but the staff quickly kind of stopped what they were doing to listen to their stories and gather their input. So the model that we're taking right now is that when they do present to the Emerge, we're having a little bit of a huddle at the nursing station in the middle of everything to discuss what their story, their background, how they're here supporting us. And then we actually do case reviews of the patients that are currently in the department, what their plan of care is, what our discharge plan is going to look like, and then get their feedback on any opportunities for different approaches. They've really provided a different lens to the frontline staff, and I'm seeing the rapports building week by week. So looking forward to them becoming consistent staples in our department.
Thank you, Kaylee.
That's wonderful. Thank you both so much. And I'm hoping you can both stay on and we can hold some questions if anybody has any questions. I think we're still waiting on Mike. So apologies if we don't manage to get him online in time. Maybe we can share some comments from him in the follow-up to this meeting. So we'll give him a little bit more time and hopefully he can join us. If not, we'll try to get comments from him later on. Thank you so much. Leanna, I'll get started on the measuring the impact we have planned for this, but do let me know if you want to jump in at all. So measuring the impact of this pilot program, obviously with the OHT, OVOHT and OHT generally, the patient experience and the provider experience are big priorities, impacting that, improving the experience for both the provider and the patient. So we'll be measuring this pilot as those are our focus for this initiative. Measuring the patient experience with the client perception of care tool, which is already utilized by Mackay Manor. So we'll be using that to evaluate the improvement in the access people experience when they go to ED for mental health addictions and substance use health care, and then are referred to Mackay Manor for more services. the provider experience. So we're hoping in the next few months to talk to PRH and Mackay Manor staff to see how their experience is. Wonderful to hear from Kaylee and Courtney about how well it's going so far, and really hope to speak with the staff about what's going well, what can we continue to improve, and a little bit more about the pilot, how it's impacting their experience. The Mackay Manor, just getting some process numbers as well. So we'll be interested in how often this can occur. We know the ED is very, very busy. So getting some process numbers about when this is actually able to occur bi-weekly as planned, and whether or not there are any impacts, any barriers or other kinds of impacts we need to consider there going forward. As well as just the screening, referrals, and connection to care. Do we see an increase with the referrals and the connections that are made from ED to Mackay Manor for addictions and substance use health when people access the ED as a point of care? So hoping to be able to share those with the members in the coming weeks and months as we gather more information about how this pilot is going. Leanna, did you have anything else you may wanted to add there?
I don't think so, Em. I think you covered everything in terms of what we're going to be looking at.
Perfect. Thank you so much. So thank you, everybody. So I still do not, I think, see Mike. I'm sorry about that. Again, we were hoping to have Mike speak. We will try to cover that in a follow-up to this session. So I think we'll move on to a Q&A. If our partners are able to stay and answer any questions and hopefully participate in discussion, we'd love to hear if any members have any questions for the partners. Melanie, thank you so much.
Yeah, thank you very much for this great presentation and great initiative. It's really good to see it in action. I know we've talked about it at the committee level, but to see just how it kind of has evolved is great. Maybe a question for Kaylee in terms of, I know that the staff have received the training. Do you have any feedback on the training and how the staff have received the training, their thoughts on it, and just their overall perception? Because I know it was a big heavy lifting to get everybody, as many staff as possible, trained, but just maybe their feedback as to it, that would be great.
Sure. So overall, it was positive feedback from those that were able to attend. I think it was valuable having a person with lived experience that was delivering it, just to provide that lens. And then they really felt that the terminology, like addressing the terminology of what sometimes they're just afraid of what to say and what not to say. So they felt that that was really beneficial to the care that they're providing, and that it's okay to not have the answers all the time and to know what to do in each situation, but just to know how to approach it and where to find those resources. That's kind of the gist of the feedback that I received.
Great, thank you. Any other questions or comments from the group? Neil, you have to have a question. Okay, go ahead.
Oh, yes. Good morning, everyone, and thank you for that presentation. I think that's very exciting to have. Anecdotally, I know I've had informal comments from staff expressing the need for peer support with lived experience with substance use. So I think that fits right there. So it's definitely, it validates that. Can you help me understand a little bit better what will be the role of the peer support worker in the ED as it relates to, if there's a role, as it relates to connecting with the client on site or after the ED visits, or what does that look like? What is the enabling role when it comes to that connection from ED to community, and just get a better picture. Thanks.
I can try to answer that. What we're hoping for, it's based off of another model, and I wish I could remember which hospital is doing it. I went to a presentation Center of Excellence had several months ago, and one of the hospitals actually has peer support workers in the ERs, and is sort of that point person for staff there, doing very similar to what Kaylee was talking about in terms of what the peer supports are doing right now in those huddles, but they're there to offer support to the staff in terms of getting that individual to the right resources. I hope that helped.
So, yeah, so then not so much the ED patient peer interfacing necessarily, but really promoting the connection.
Yes.
Aside, okay. Thank you.
I think the goal for phase 3 is to have that connection with the peer support worker and the patient that's in ED, and working one-on-one with them as well, because sometimes patients who are arriving to ED, they won't stay or they leave early. So hoping to try to make sure that these people get connected to the right supports before taking off.
Brigitte?
Thank you, Emma. So I just had a question to tack on to that. So I think it's amazing to have that kind of peer support coaching element for providers. I'm wondering if there's any way to access that through the community to Mackay Manor, like for peer support, for this type of peer support. Do you offer this to other disciplines, or is it really like just a pilot project that's working with the emergency department right now?
Currently, it is just a pilot. Mike, who went through all of the training, and is actually a certified peer specialist right now. He just got that when April or May, somewhere around there. He was certified, and we have a couple more staff who are going through that training right now. So I think, you know, anything and everything is possible in terms of where we roll this out and how we roll this out. Right now, as a staff person, Mike has become our peer support specialist at Mackay in the inpatient program. But you know, absolutely, the sky's the limit. As the more that we can offer folks, and with through MESA and SUAP, those are also very big components of both of those initiatives as well. So peer support will be offered in the community.
Great, thanks very much, Leanna.
Sorry to jump in. I think I just saw Mike jump on, so we'll just jump back in our slides as well to have Mike speak if he's on the line here. And Leanna, maybe you can speak a little bit more of the SUAP as well. That was really exciting news. So maybe once we get back to our discussion, you can give everybody here just a little bit of a information about that as well. Mike, I think I see you on the line. Can you let us know if you're here?
Hi, everybody. Yeah, I'm here, and I'm so sorry I'm late. And yeah, so yes, I'm here. Do you want me to wait, or do you want me to talk now? Cool.
Absolutely. My apologies if you had technical difficulties, Mike. I'm so sorry for that. Thank you so much for joining us. And yeah, we went through a few of the slides, but we'll just jump back to yours if that's okay, and give you the floor to speak, and then move back into Q&A and discussion with the members.
Okay.
Thank you so much, Mike.
So my name is Mike Morrison. I'm a peer support specialist at Mackay Manor. I just got certified in May, and I'm currently doing the ED rounds with community withdrawal management services at Pembroke Regional Hospital. And yeah, I guess ultimately, I mean, I'm a person with lived experience, right? I come from the same place as a lot of our clients do, and as a result of that, I think, well, from my experience, you know, part of the reason I'm here is because I have people with lived experience in my life that definitely influenced and helped me get to where I am today, right? Get to have the sobriety I have today, and I do know a lot of people that struggle with people with education only and not lived experience, and communicating with them. So I think that, to put it bluntly, I know that when it comes to the ED rounds, you know, we have a very, I was only interested in coming to get recovery for a very small window of time, right? When I was desperate and when I was hurting, and that little window is where we can get people. And so if I can be part of that and, you know, say, hey, you know, look at me, you know, I get where you come from, but I managed to get clean and sober, then I'm all for trying to get people at that small window of time that we have, right? So that's ultimately, I think, what the goal is, with what we're doing through Mesa, right? Is trying to get people where they're at, and if harm reduction is the option, the only option we have, then definitely we go down that road, because at the end of the day, we don't want people, you know, we don't want to lose any more people to this disease. But at the same time, getting them in that small window of time where they're willing to come is one of the areas that I'm looking to focus on, right? So and I don't know what else to say besides that. Sorry.
Not at all. Thank you so much for that. That was great. Thank you.
No problem.
I'll stop sharing. Thank you so much for that. And I will open it up again for any questions that you might have for Mike or any of the other partners, and anything you might want to discuss. Thank you again, Mike. So glad you could join us.
Oh, you're welcome.
Questions? Oh, great. Thank you, Murray.
Yeah, I just what Mike just said about that window of opportunity being very small and needing to capture that moment. I just want to share that my very first day on this job many years ago, I just walked into a process mapping of service resource, and there was someone on part of that group with lived experience, and that's exactly what was said, is that there's only so much time that we have to seize the moment, and when that person is ready, and so we have to be ready when the person is ready. So it just really connects, Mike, with what you just said, and it certainly felt true there, and finds true. So thank you for what you do.
Absolutely. You're completely welcome. Thank you for letting me be part of this.
Any other questions for the partners? We'll give you a few more minutes. We'll do a little bit of housekeeping just to wrap things up. But if any questions come up, please raise your hand. And I think the partners are happy to take some more if you do have any. But we'll just do a little bit more housekeeping, just wrapping up the session. As always, we really appreciate hearing what you thought about the session. Please let us know through the Mentimeter. It should be in the chat as well if you'd like to go there to give us your feedback about the session, what you might like to see differently and see in the future. So thank you so much. Please find that in the chat. And please let us know what you think. Also, save the date for our next mini-series. And sorry, I do see some more hands, so I'll just say this next mini-series is August 20th. Please save that date. You'll be receiving the invite shortly. And we'll go back to the chat because I think I see a hand. Thank you so much. Maria, I think your hand is still up, so I'll let us know if not. Otherwise, Bridget, thank you.
Oh, Maria, I think you're on mute.
It was an old hand, sorry.
Okay, thank you. So Mike, this is a question for you. So we talk about like being ready in the moment when our patient or our client is ready. Do you have any recommendations for healthcare providers for when that individual is not ready for help? Like, is there any follow-up that we can prioritize for those cases to promote access to services moving forward that are related to addiction supports, or even just general safety for the patients?
So yeah, I mean, it's tough, right? Because as you well know, as a healthcare worker, most times, luckily I wasn't one of these, but most times they'll wake up angry, right? Or at least trying to get out the door at ASAP, right? And yeah, we talked about it last week, actually, during our meeting at PHR or PRH, which was, yeah, they're starting to hand out a naloxone, right? And kits. And then I also said, maybe we add the card that's the NORS hotline, right? Because ultimately a majority of these clients are going to probably go back out and use, right? And so adding the NORS National Overdose Response Service line 1-800 number is something that we add to the naloxone kit that we hopefully can convince them to take with them, so that even if they are going to use, they'll phone that number and not be alone, right? Not overdose without contact. Short of that, I mean, I think part of the reason that I'm involved, I'm trying to get more involved in this, is because hopefully by talking with somebody with lived experience, if that opportunity presents itself, hopefully they won't leave. I mean, I wish I had a solid answer for you, right? I don't. Try, when I was, the times that I overdosed and I was in there, I got to talk to a social worker who was a really good social worker. This was in Hamilton, right? But I already didn't want to. I knew that part of me didn't want to be doing what I was doing. So I was already on my way to getting better, I believe. Plus, I was surrounded by a lot of people with lived experience, right? Through going to the rooms. So no, I think that all we can do is keep working on our communication, right? Keep working on, maybe. I was talking to my sister-in-law who works in advertising for big pharma, and she has done a bunch of tapes, or at least they've done a bunch of practice tapes when it comes to talking to clients in different situations. And maybe that's something we have to work on with the hospital, right? So that you guys have examples or different scenarios that you can refer to as a practice thing. Because no, I don't believe there's anything set in stone. Every client's going to be different, and there's no guarantee getting them when they want to be there. But how often does that happen, right? I mean, sorry, sorry to go on and on. I wish I had the exact answer. Yes, I recommend the 1-800 NORS number. If you are aware of what that is, put in with the naloxone kit, and then, yeah, get them talking to someone who, which you already do, I'm sure, talking to someone that hopefully gives them ideas of where to come. And that's off the top of my head. I'm sure there's way better ideas out there, but I don't have them all yet, right?
No, I think that's great feedback, and I think it's really like maybe just making sure that the right linking to resources is provided in a, like you talk about the window, maybe it's not a window of opportunity to actually access like addictions resources or like transition to a center, but maybe it's the window of providing the naloxone kit, providing the right telephone numbers, the right telephone contacts, so that like, although the individual is leaving or not choosing to follow through with additional treatment, they still have access to that,
Yep.
to the resources if the time comes, Thanks very much.
Absolutely. Yeah. I keep saying I'm going to do this, but I actually, I'm friends with the director of NORS, right? Because she got clean in Hamilton the same time I did. So I need to get a hold of her and confirm how that system works. But But as far as I know, all they have to do is phone the 1-800 number and they'll call an ambulance if they don't, if the communication is interrupted, right? If they're concerned that there's an overdose. And so, yeah, I think that's hugely important to add to our kit that we're handing them, because I just don't know how to encourage them to use it. That's going to be the hard part, right? Yeah, oh, sorry. That's that's all I got right off the top of my head. But I think all we can do is keep trying, right? Yeah.
Well, thank you so much for that, Mike and Bridget. That was really helpful. If anybody wants the NORS number and wants more information, we can make sure it goes out in the follow-up as well. Not sure if Kaylee or Courtney, did you have anything to add there? That was really great. Thank you so much for that, Mike. Any other thoughts that may have brought up? Any other questions?
Just to add on to what Mike was saying, like reiterate basically the same things he's saying. Keep trying, you know, and you know, if they're not ready, then there's nothing really that we can do. It's just ensure that we're here to support and we're here to offer services when they are ready. But given if they aren't ready, just giving them those resources to use safely. Yeah, Kaylee, I don't know if you have anything else to add.
Not too much that I think just hearing it from Mike and the staff hearing it from Mike, that, you know, that's where often the staff get frustrated because they're trying to help these individuals and they see them come back day and day and the following week and the following week, and they feel that they're not doing enough and that they should be doing more, and that just leads them to getting frustrated with the whole situation. So hearing from Mike just that reassurance that you're not going to be able to save this person every day, but every encounter matters, I think that's helping just that overall picture.
Yeah, please know that I appreciate, oh, sorry, I'm cutting in, but that because of where I come from, I appreciate what you guys do. And believe it or not, all those people that are angry at you and when they wake up or just take off out the door as soon as you're not in the room, they do too. They're stuck in their own stuff, right? I mean, I think that's part of the reason. Somebody told me a while ago that the NORS card that they've made up is a credit card, right? And it's funny that it's a credit card because, you know, what is an addict going to do with a credit card? But the reason I think they made it that way, and I'll confirm this with Kim, but chances are the reason they made it that way is because they know they'll keep it there, right? So that's kind of what we're trying to do is, you know, treat them where they're at. And that's maybe where our ideas come from, is trying to see from where they're at, what's going to attract them, right? So anyway, thanks.
Thank you so much. I know that's probably so helpful for everybody on the call here who's had the same situation and really needs that expertise and that information. Thank you all. Any other last call for any other questions or comments? Just want to send a big thank you to all the partners, Mike, Kaylee, Courtney, Leanna, Melanie. Thank you all so much. It's been so great to have you, so informative, so great to hear about this project. I know there's some thanks coming in the chat box as well. Thank you all for your time. Thank you to all the members who joined us today. And if there's no other questions, we'll let you have your time back. And thank you all again for joining.